So welcome to the recall sessions of September 2024. The question number one, a 35-year-old man presents with a 3-week history of low back pain and a 3-day history of pain and weakness in his left leg. Physical examination demonstrates numbness over the posterior aspect of the left calf extending to the lateral aspect of the foot. Left ankle reflex is absent. So MRI has been done and it shows compression due to deficiency of which structure. So typical PLID cases, the correct answer should be the annulus fibrosus. Let's submit the answer. Now, the explanation of this one has been given, short description has been given here. Is you can see this one, that nucleus pulposus produced through a deficiency of annulus fibrosus. So a disc herniation occurs when the nucleus pulposus is a gel-like material herniates through a deficient or the torn annulus fibrosus. So the structure that has deficiency is the annulus fibrosus, but which structures protrude the nerve root? If this question has been asked, that would be the answer of nucleus pulposus. So the clinical scenario is given if they ask about which nerve compression ankle reflex is lost. So the nerve root here should be S1, sacral 1 nerve root compression, at where is classically seen lumbar 5 and S1 disc herniation, L5 X1 disc herniations. Now the other options given here is anterior longitudinal ligament. What's that? It runs along the anterior surface of the vertebral bodies and resist hyperextension. It rarely involved in the posterior disc herniation because it lies anteriorly. So what about the posterior longitudinal ligament? Options number 4 here. This ligament may be breached in large disc herniations. The primary structural defect occurs in annulus fibrosus. The posterior longitudinal ligament is a secondary barrier. So if the question asked, other than the annulus fibrosus, what structure might be the responsible for the disc herniation, then the posterior longitudinal ligament could be the answer. The final one, vertebral end plate. So deficiency of these structures causes Schommel's nodes, SCHMORL, Schommel's node, which is very rare question to be asked by the RCS, I guess. So when the disc material herniates vertically into the vertebral body, this does not cause lateral nerve root compression. So keeps in mind vertebral end plate. The option number 5 here, vertebral end plate, is responsible for vertical disc herniation, not the lateral nerve root compressions. Okay, so go to the next questions.
This video is brought to you by MedExamPass. To access the complete recall sessions, including the latest updates from 2025, do visit www.medexampass.com.
Please check description for details. Question number 2 is given. A question is there is a enlargement of tonsil with fever and respiratory problems, difficulty. So what is the correct answer? That usually the tonsil related questions, this is most probably is the peritonsillar abscess. It is the right answer, and what are the descriptions have been shown here is a peritonsillar abscess. Now the explanations behind this one, what is peritonsillar abscess, or in Quincy it has another name. So it's a collection of pus between the tonsillar capsule and the superior pharyngeal constrictor muscle. Keep that in mind. Tonsillar capsule and superior pharyngeal constrictor muscles in between the pus form. So it's a complications of acute tonsillitis and represents the most common deep infections of the head and neck in the young children. So usually they have unilateral tonsillar swelling, they have uvular deviation to the opposite side, trismus, hot potato voice or muffled voice, very typical scenario. Dribbling or drooling of the saliva, and the fever and some systemic toxicity could be found. So what are the other differential options have been given here? Ludwig and diphtheria. Ludwig is the bilateral submandibular space. Keep that in mind, very important. Bilateral submandibular space infections causing floor of the mouth swelling, so tongue elevation, potential airway compromise. It doesn't cause uvular deviation. It does not cause uvular deviation. Keep that in mind. It's very important and key word to differentiate peritonsillar abscess and the Ludwig angina. What about the diphtheria? It is characterized by a pseudomembrane which is gray in color, adherent to the tonsil and the pharynx. Along with the cervical lymphadenopathy, we can found bull neck, we call it. So it doesn't cause unilateral tonsillar swelling. It does not cause unilateral tonsillar swelling or uvular deviations, nothing. But diphtheria is very rare because of the vaccinations. Okay. Now the question number 3. It says that a 58-year-old woman presents with the exertional dyspnea and pansystolic murmur based out of the apex. Her ECG shows a bifid P wave. So bifid P wave is the key word here. So bifid P waves means patient has a left atrial enlargement. Keep that in mind. Left atrial enlargement. Okay. So the left atrial option C is being given due to the mitral regurgitations. Let's submit it, and this is the correct answer is given here. So what is the explanation? In mitral regurgitation, blood flows backward from the left ventricle into the left atrium during systole, and this causes chronic volume overload, and progressive dilations of the left atrium. The enlarged left atrium takes longer to depolarize and protruding a bifid or notched P wave duration more than 3 small boxes or 0.12 seconds in lead to. This pattern, this double notch P pattern is called the P mitral. Okay, so it's a very typical scenario. So now what about the right atrial enlargement? What does it mean? Right atrial enlargement means cor pulmonary, and it is, you can find here peak T wave, not bifid, but P will be very tall, almost more than 2.5 millimeter in lead to, typically seen in chronic lung disease. Right ventricular hypertrophy, it manifests as right axis deviation, and what we found in R wave will be very tall in V1. What about the left ventricular hypertrophy? Here R will be very tall, but not in the V1. It's most probably V5 and V6. The P will be very tall, and left ventricular hypertrophy does not have any P wave changes, so that we can exclude it from our possible diagnosis. So right answer is the number 3. Next questions number 4. Which muscle from the lower border of the triangular spaces? Very much typical questions is a teres major. Typically most of the students got wrong, click the teres minor, but no, it's the major. So explanation has been given here. You can see the border of the quadrangular space, superior teres minor, inferior teres major, superior minor, inferior teres major, medially long head of the biceps brachii, and the laterally surgical neck of the humerus. Next questions. Patient presented to the emergency department with a multi-fragmented patella fracture. Most appropriate treatment. So most appropriate treatment sometimes could be the patellar band wiring, but if it is being open, when the patellar fragment is both open and severely communicated, the bone fragments are too often too small to contain to allow reliable reconstructions. So in such cases, actually what we do is a total patellectomy is better to do it here. Tension band wiring was most probably could be the reason. We could answer it was one of the time, but the right answer here supposed to be is patellar excisions or patellectomy. That is the correct answer, but I hope in here there might be yes, this is the correct answer has been put here. Yes, this is the patellectomy is the correct answer here, not the tension band wiring. Come to the next questions now. Let's just go back. Why not the tension band wiring? What is the ideal scenario? This is the ideal treatment for transverse or minimally comminuted patellar fracture with large and reconstructible fragment. So the pieces of patella, fragmented piece of patella, should be large enough, and it should be transverse. If these two criteria meet, we could go with the tension with band wiring. For these questions, multi-comminuted, do the patellectomy, reconstruction of the patella, just excise the whole patella. Okay. Question number 6. A 32-year old athlete comes to the stiffness and back pain on the operation OT on the CT scan. A space on CT scan, space between the transverse process of the vertebra is reduced less than 2 centimeter. So he experienced a pain on spine extensions. So what's the diagnosis? Very typical scenario is a ankylosing spondylitis typical scenario. So what are the key features of ankylosing spondylitis? A morning stiffness that improves with activity, reduce spinal mobility and checks expansion, sacroiliitis, inflammation of the sacroiliac joint, that is the earliest finding, and progressive spinal fusion leading to the bamboo spine on X-ray. This is a very, keep in mind, bamboo spine on X-ray is the key word for ankylosing spondylitis. And most important, 90% cases HB27, HLA-B27 can be found positive here. And what are the extra-articular features? Patient may have uveitis, aortic regurgitations, and apical lung fibrosis could be found here. Explanations have been given here, and if we try to differentiate the other diagnosis, what about the rheumatic arthritis? So it affects the peripheral joints symmetrically. Symmetrical peripheral joints will be involved. Not that spine involvement is very limited, but even if it's involved, it's supposed to be in the cervical spine, especially the first one, as atlantoaxial subluxation is the very common features of rheumatic arthritis. And usually and almost it does not cause diffuse spinal fusion. Rheumatoid arthritis doesn't cause these special features. Another one, spondylolisthesis, is a forward slipping of one vertebra on another one. Spondylolisthesis is usually found on the L5S1, present with instability and radiculopathy, but not progressive fusion. Vertebral disc prolapse, this causes acute radiculopathy or sciatica-like pain with positive straight leg rise test, doesn't cause chronic stiffness, diffuse fusion, or reduce intertransverse space. So ankylosing is the correct answer here. Let's go to the next one. Question number 7. What is the following is no relation with left ureter? The correct answer is the round ligament of the uterus. There was the relations of the ureter in the pelvis. Keep that in mind. So it crosses the pelvic rib at the bifurcations of the common iliac artery. Then it passes under the ovarian artery or testicular artery in male, runs along the lateral pelvic wall, that is very much related with internal iliac artery, and in female it passes under the uteric artery. So that's the keyword, water under the bridge. Water under the bridge. Why is it important? Ureter passes under the uterine artery in case of female. This word is keyword, keep that in mind. And finally, it's related to the sigmoid mesocolon on the left side. Sigmoid mesocolon on the left side. So sigmoid mesocolon is the number 2 options. All of those structure here are related with the ureter except the round ligament of the uterus. Question number 8. A 36-year-old presented after 12 hours of trauma with a 12 into 3 centimeter wound and exposed tibia. So what is your management? So exposed tibia, that's the important thing. So is the free flap. That is the correct answer. A large wound with exposed bone requires a vascularized soft tissue coverings. The tibia has minimal soft tissue coverage, especially in the distal third, making it vulnerable to infection and non-union if bone remains exposed. So what is the principal management? Initial management is a vascular compromise, compartment syndrome, associated fracture, then the debridement. We do the irrigation, do the debridement, then we give the antibiotic, then the soft tissue coverings. Now, the flap options, if been asked, just asking. So in tibia, we divide it into 3 parts: proximal third, middle third, and distal third. For the proximal third, usually gastrocnemius soleus muscle flap. For the middle third, soleus muscle flap. And for the distal third, usually we do the free flap. So usually we do the free flap, latissimus dorsi, LD flap is the commonly being used here. Going to the next question. Question number 9. A pulsatile mass on forehead with thyroid mass. What is the diagnosis? So it's a thyroid cancer being given here. Follicular thyroid cancer is the best possible options here to answer. It is the second most common thyroid malignancy. So what is the first one? It is the papillary carcinoma. But unlike papillary carcinoma, follicular carcinoma spreads via blood. So it has a hematogenous route of spreading, then the lymphatic spreading. So lymphatic spread by what? Lymphatic spread by most common thyroid carcinoma, papillary carcinoma. Second most is the follicular thyroid carcinoma. Follicular thyroid carcinoma goes by blood. Now, second questions. Related questions could be asked. Metastatic pattern. What are the most common hematogenous secondary spaces or metastatic spaces for thyroid? Bone, lung, brain, liver. Bone is the most common. Skull, vertebra, ribs, pelvic, long bones, high vascular and often pulsatile. So bone metastasis is very, very, very common for the follicular thyroid carcinoma. Second one, lungs. And so a pulsatile mass on the forehead represents a highly vascular body metastasis of the calvarium of the skull, which is pathognomic for follicular thyroid carcinoma. Now, next questions. Post-thyroidectomy, loss of high-pitched voice. Very typical questions asked, and must questions for asked. Nerve injury during thyroid operations. So in here, high-pitched voice is responsible by the cricothyroid muscle, and that cricothyroid muscles is supplied by the external laryngeal nerve. External laryngeal nerve. Show the descriptions. So this nerve supply of the larynx is very, very, very important. So it has voice fatigue, reduced vocal range, professional voice user, usually singer, teacher. The most affected part, external laryngeal nerve. Keep that in mind. Now, what are the other options? Internal laryngeal nerve and recurrent laryngeal nerve and vagus nerve. Now, internal laryngeal nerve, which is a branch of superior laryngeal nerve, provides the sensory innervation to the larynx above the vocal cord. Injury causes loss of sensation, leading to aspiration risks, but does not affect voice pitch. Keep that in mind. Second, recurrent laryngeal nerve. It innervates all intrinsic muscle of the larynx except the cricothyroid muscle, which has been given here. Unilateral injury causes hoarseness and breathy voice due to vocal cord paralysis in the paramedian positions. But bilateral injury causes severe respiratory distress and stridor. So patient presented with stridor or severe respiratory distress, click bilateral recurrent laryngeal nerve injury. Now the vagus contains both superior and recurrent laryngeal nerves. Complete vagal injury would cause combined sensory and motor deficits, not isolated loss of high pitch. Next questions. Now, parasympathetic nucleus to the lacrimal gland. What would be the possible answer here? The superior salivatory nucleus is the correct answer. We give this. Yes, this is the correct answer. So the pathway of lacrimation is very much important. Is usually originated from the superior salivatory nucleus, then by facial nerve it travels, go to the greater petrosal nerve at the geniculated ganglion, then join the deep petrosal nerve, the sympathetic nerve, to form the Vidian nerve of pterygoid canal. So Vidian nerve is the nerve of pterygoid canal. Then it synapses with the pterygopalatine ganglion, and postsynaptic fibers travels to the zygomatic branch of the maxillary nerve, then by the lacrimal branch of the ophthalmic branch to reach the lacrimal gland. So in short, the superior salivatory nucleus is located on the pons and gives rise to preganglionic parasympathetic fibers that provide secretomotor innervation to the lacrimal gland. What about the inferior salivatory nucleus then? It is situated on the medulla, gives rise to preganglionic parasympathetic fibers that travel to the glossopharyngeal nerve via the lesser petrosal nerve to the synapse in the otic ganglion, which innervates the parotid gland. Keep that in mind. Lacrimal gland, superior salivatory. If asked about parotid gland, then click inferior salivatory nucleus. What about nucleus ambiguous? Nucleus ambiguous 9 and 10. Motor nucleus for the 9 and 10. Providing motor innervation to the pharyngeal and laryngeal muscle. It is not involved in any parasympathetic secretomotor function. Okay. Next question. A 65-year-old patient with muscle invasive bladder carcinoma undergoes radical cystectomy during the pelvic dissections. A branch of the anterior divisions of the anterior iliac artery is transected. So what would be the correct answer here? So inferior vesicular under the bladder, blood vessel under the bladder. So it is the anterior divisions of the internal iliac artery. So it supplies the bladder from the base, then the prostate in males, seminal vesicle, and distal ureter. It is the artery most commonly encountered and at risk during radical cystatectomy. So what are the things we have to know here from here? So branches of the internal iliac artery, anterior division and the posterior divisions. The anterior divisions, there are eight, around eight, I guess. Superior vesicular, inferior vesicular, obturator artery, uterine artery in female, middle rectal artery, internal pudendal artery, and inferior gluteal artery. Seven, I guess. Yeah. And the posterior divisions, only three. One is superior gluteal, iliolumbar, and lateral sacral branch. That's the posterior divisions. Okay. Now, if the same question been asked, let's ask a different questions. Let's say during a hysterectomy, a profuse bleeding occurs from the branch of the anterior division of the anterior artery located near the cervix at the level of the internal os. Which artery is the injured? Same questions. Now, answer is the uterine artery because the artery crosses over the ureter at this location. Water under the bridge. Just few questions before we discuss this one. So the summary is this one's uterine artery is very much near to the internal iliac artery. Ureter is very much near to the internal iliac artery. And on the anterior division of the internal iliac artery, uterine artery or vesicular artery is commonly encountered during either hysterectomy or prostatectomy. Next question. Question number 13, precursor of isoprenaline, which act on beta 1 at low dose and alpha 1 at high dose. What is that? That is the adrenaline. That is the adrenaline is the right answer here. The dopamine has been given here, but that is the wrong. Keep that in mind. Adrenaline is the right answer here. So adrenaline exhibits or epinephrine exhibits the dose-dependent receptor sensitivity. At low dose, it has stimulates both beta 1 and beta 2, but at high dose, it only has alpha 1 receptor. Next question. Number 14. A patient with atrophic gastric mucosa, autoimmune disease, and thyroiditis presents for evaluation. What will the peripheral blood smear show? So here we see a large and oval red blood cell. I mean the macroovalocytes commonly should be seen here because it's a pernicious anemia. It's a case of pernicious anemia, autoimmune disease characterized by the destruction of the gastric parietal cell leading to the loss of intrinsic factor productions. Without intrinsic factor, vitamin B12, another name is cobalamin, remind it, cannot be absorbed in the terminal ileum. So what's the pathology? Very much simple, autoimmune destruction of the gastric parietal cell, loss of intrinsic factor, impaired absorptions of vitamin B12, and finally megaloblastic anemia. Due to what? Due to impaired DNA synthesis. What would be the laboratory findings? One, in the peripheral blood film, the cell will be very much large in size, macroovalocytes, large oval red blood cell, and hyper-segmented neutrophil. Keep that in mind. Hyper-segmented neutrophil, more than 5 lobes. So MCV, mean corpuscular volume, will be very high, more than 100 femtoliter. Serum B12 will be low. Homocysteine and methylene blue, that will be elevated. Anti-intrinsic factor antibody, if we found blood test, it will be found. Very much specific test. And anti-parietal cell antibody, it is very much sensitive but less specific. What's the two antibody? Anti-intrinsic factor and anti-parietal cell. Anti-parietal cell is very high sensitive but low specificity, but anti-intrinsic factor antibody is very much specific. Next question. Indications for thyroglosal cyst surgery in children. So why? Because it is one of the causes. It's a congenital defect, midline of the neck, commonly seen in the children. It arises from the remnants of the thyroglosal duct. So repetitive infection is the most common indications we have been found. So what is thyroglosal cyst? So thyroglosal cyst is the most common we see congenital midline found. It's a remnant of the thyroglosal duct, so which normally evolves during fetal development of the thyroid gland, descends from the foramen cecum at the base of the tongue to the final position in the lower tongue. So what is the clinical features? It moves upward, and tongue protrusions with swallowing is a key diagnostic feature, and usually asymptomatic, but may become infected and occurs at anywhere along the path of the thyroid descent. So when we do the surgery, four indications. First indications is recurrent infections that has been given here. What are the other options? Progressive enlargement causing compressive symptoms, compressing the air compressions, respiratory distress. So progressive enlargement is another indication. What's the third? Cosmetic search concern, nothing problem, but I have a cosmetic concern on the patients. And finally, very important, suspicion of malignancy, though very rare, less than 1% cases. Usually, even if the malignancy have been found, we could find papillary thyroid carcinoma. In thyroglosal cyst, the clinical diagnosis, after the biopsy, if any malignancy found, there is a chance malignancy, and that malignancy supposed to be papillary thyroid carcinoma unless proven otherwise. Keep that in mind. So that is the number 15 questions. Welcome to the next sessions. Thank you.